Welcome to the Deep Dive, where we help you rapidly review essential content for the Plastic Surgery Board exam,
Today we're focusing on the facelift.
a procedure with nuances that often appear on the exam.
Right. To start, let's break down the science behind an aging face, which is critical for understanding the rationale behind a facelift.
Okay, so intrinsic and extrinsic factors both contribute to facial aging, correct?
Yes. Intrinsic aging involves the natural processes that occur over time, like the thinning of the epidermis, slower cell turnover, and decreased collagen production.
You'll need to understand these histological changes for the exam.
Extrinsic aging is primarily caused by environmental factors like sun exposure and smoking.
The source material mentions a startling statistic about smokers and facelift risks.
Yes, smokers have a 12 times greater risk of skin sliff after a facelift.
Wow.
This is because smoking compromises blood flow to the skin, making it more susceptible to damage and necrosis during and after surgery.
So when analyzing a patient for a potential facelift, it's essential to consider their smoking history.
Absolutely. Now let's move on to the visible signs of aging, starting with wrinkle formation.
Okay.
The material outlines 3 types of wrinkles.
Can you elaborate on those?
The first type is animation creases, which are dynamic wrinkles that form due to repeated muscle movements like smiling or frowning.
Okay.
Then you have fine wrinkles, which result from the breakdown of elastic fibers in the dermis.
Okay.
Lastly, there are coarse wrinkles typically caused by sun damage, also known as solar elastosis.
Histologically, what changes do we see with wrinkle formation?
You'll see a loss of dermal papillae, a decrease in the number of melanocytes, thinner skin overall, and alterations in the structure of the dermis.
The source material also details how soft tissues change with age.
Right.
It outlines 4 key mechanisms.
The first is descent, simply gravity pulling everything downwards. Deflation or volume loss, particularly in the midface and upper face, is another key factor.
Okay.
Interestingly, the inferior orbital rim doesn't actually droop. The appearance of drooping is caused by volume loss in the surrounding areas.
Oh.
Fat accumulation, especially in the lower third of the face leading to jowls, is another change.
Okay.
And lastly, there's radial expansion, where repetitive facial expressions stretch the retaining ligaments, causing soft tissues to move away from the facial bones.
Interesting.
This is often most noticeable in the nasolabial folds.
So it's not just about wrinkles, but also about how the underlying structures shift and change over time.
Exactly. And we can't forget about bone remodeling, another important aspect of facial aging.
What are the key bony changes we should be aware of?
The infraorbital rim and anterior maxilla recede with age, contributing to the appearance of tear trough.
Okay.
The orbit itself expands and the facial skeleton continues to grow even as we age.
Uh-huh.
However, bone demineralization or tooth loss can lead to a decrease in overall facial height.
Makes sense.
The key takeaway is that facial structures rotate downward and inward relative to the cranial base over time.
Now, shifting gears to the practical aspect, let's discuss preoperative facial analysis.
Evaluating the entire face is crucial. This allows us to avoid creating a patchwork effect where one area is treated in isolation.
Got it.
Also, it's essential to identify any high-risk patients, such as smokers, individuals with hypertension or diabetes, and those who use NSAIDs chronically.
We already discussed the increased risk of skin slow in smokers.
Yes.
Are there any other specific considerations for those with hypertension or diabetes?
These conditions can affect wound healing and increase the risk of complications.
Right.
Careful blood pressure management is crucial for patients with hypertension both during and after surgery.
Oh.
For those with diabetes, we need to ensure their blood sugar levels are well controlled to optimize healing.
So a detailed medical history and thorough preoperative assessment are essential.
Precisely. And don't forget to consider skin resurfacing techniques like laser or chemical peels.
Okay.
These can be performed before a facelift to improve skin texture and address superficial wrinkles.
Moving on to the actual analysis, how should we approach it systematically?
The source recommends dividing the face into zones: periorbital, perioral, and neck.
Makes sense.
This allows for a methodical assessment of each area.
Let's start with the periorbital zone.
Okay.
What are the key things to look for?
In the periorbital zone, which includes the forehead, brow, and midface, you want to evaluate brow position, forehead height, glabellar creases, and the temporal region.
Okay.
Look for crow's feet, excess skin, and any signs of atrophy in the temporal area.
Got it.
Assess the upper eyelids for pantosis, the lower eyelids for lid tone festoons and tear trough deformity.
Yeah.
Note the lateral canthal position and the projection of the malar eminence.
What about the perioral zone?
In the perioral zone or lower face, focus on the nasolabial folds, marionette lines, and the angle of the mouth. Assess the upper and lower lips for volume length and rhytids.
Sir?
Examine the chin for labiomental fold depth, ptosis, and jowls.
Okay.
Finally, assess the nose for any deformities and the ears for lobular
Then
pitosis.
lastly, the neck zone.
Right.
What are the key considerations here?
In the neck zone, look for excess skin platysmal bands and the amount of subcutaneous and subplatysmal fat.
Okay.
You also need to determine the ideal extent of neck skin elevation to achieve a natural-looking result.
Right.
This usually involves elevating the neck skin past the inferior border of the platysmal band.
Before we move on to specific facelift techniques, let's discuss facial proportions and their influence on the surgical approach.
Analyzing facial proportions helps us personalize the facelift.
Okay.
We consider the overall width, length, and fullness of the face to guide the vector of pull on the SMAS.
Okay.
This can be vertical diagonal or even horizontal.
Interesting.
It also helps us decide whether to excise excess tissue, tighten it with application, or use a combination of techniques.
Yeah.
The three key parameters to focus on are midface with facial length and facial fullness.
Now let's delve into facelift techniques, starting with incision placement.
Okay.
What factors determine the location of the scars?
Several factors come into play. The hairline sideburns the patient's Fitzpatrick skin type, which indicates their sun sensitivity and scarring tendency, and their individual ear anatomy.
The source material mentions different options for temple incisions.
Right.
Can you explain those?
You can choose a pre-hairline incision, which is ideal for patients with short sideburns, those undergoing a secondary facelift, or when removing excess skin would create an unnatural distance between the lateral campus and the hairline.
Okay.
Alternatively, a post-hairline incision is often used with an open coronal brow lift or when minimal excess temporal skin needs to be removed.
The preauricular incision seems to be a common choice.
Yes.
What are the key considerations here?
The preauricular incision is made between the face and the ear following the natural curve of the helix.
Got it.
An intertrigal incision helps conceal the scar within the ear, while a pretragal incision placed just in front of the tragus might be preferred for men to avoid displacing hair follicles. It's crucial to create a distinct angled incision at the inferior edge of the tragus to prevent a pixie ear deformity, where the earlobe appears pulled downward.
And what about the postauricular incision?
The postauricular incision is placed within the crease behind the ear, ideally within the retroauricular sulcus.
Okay.
Using consistent landmarks like the posterior auricularis muscle or the top of the tragus ensures symmetrical placement on both sides.
Okay.
When extending the incision into the occipital area, you can choose a pre-hairline or post-hairline approach.
Uh-huh.
A pre-hairline incision eliminates the need for hairline adjustments, but carries a greater risk of visible hypertrophic scarring.
Now let's move on to vectors and fixation.
Okay.
What are the ideal vectors for the SMAS and skin?
The SMAS, or superficial musculoponeurotic system, is a key layer that supports the facial muscles and soft tissues.
Okay.
Ideally, the SMAS is fixed and elevated in a vertical or diagonally vertical vector, while skin fixation should be more posterior and vertical. This vertical vector on the SMAS is critical for improving the jawline and perioral areas.
Okay.
Also, a high SMAS lift, which extends higher on the face, effectively restores the midface.
What types of sutures are typically used for fixation?
Permanent sutures are mainly used for SMAS suspension, as the SMAS needs long-lasting support.
Okay.
In contrast, absorbable sutures are used for skin closure, as the skin eventually heals and regains its strength.
The source material lists numerous operative techniques for facelifts.
Right.
Can you provide an overview of the main categories and their advantages and disadvantages?
Sure. The techniques commonly used today often involve some degree of subcutaneous dissection combined with SMAS manipulation.
Okay.
First, there's the subcutaneous facelift.
Okay.
This technique involves elevating the skin and subcutaneous tissues without directly addressing the SMAS or deeper fat compartments. It's relatively safe, straightforward to perform, and offers a quick recovery.
Okay.
However, it may not provide the most long-lasting results.
What about the deep subcutaneous facelift?
In a deep subcutaneous facelift, a thicker flap, including the skin and superficial fat compartments, is developed and redraped.
Okay.
This avoids penetrating the SMAS, and the superficial fat can be repositioned.
Interesting.
However, the flap movement is primarily unidirectional, and fixation relies on sutures placed in the fat and skin, which may not be as secure.
Next, we have subcutaneous facelifts with SMAS plication or Imbrication.
Right.
Can you explain the difference?
In both techniques, a subcutaneous flap is elevated and the SMAS is tightened without direct elevation.
Okay.
With SMAS plication, the SMAS is simply folded and sutured to itself.
Got it.
SMAS imbrication involves incising, advancing, and overlapping the SMAS, securing it with sutures.
Okay.
These techniques are relatively safe and faster than sub-SMAS dissection.
Uh-huh.
However, there is a theoretical risk of catching a facial nerve branch with the suture, and some surgeons believe the results may not be as long-lasting.
What about the minimal access cranial suspension or MECS facelift?
The MACS facelift is a variation of SMAS plication. Subcutaneous tissues are dissected and then suspended from the deep temporal fascia using long looping sutures.
Uh-huh.
These sutures have multiple bites to elevate the deep tissues in a vertical vector.
Oh,
One loop is placed for the neck, another for the jowl, and an optional third suture can be used for mid-face elevation in the extended MACS lift.
interesting.
This technique is known for its minimal invasiveness.
The suture placement for lateral SMA mastectomy technique seems to differ.
Right.
Can you explain this?
This technique is a variation of SMAS imbrication.
Okay.
A strip of SMAS is excised parallel to the nasolabial fold, and the mobile SMAS is advanced after excision.
Okay.
The SMAS is not undermined in this procedure, making it suitable for patients with a full face who may benefit from removing some deep tissue excess. It provides a more complete raw surface on the SMAS, which some believe contributes to longer-lasting results.
We also have SMES stacking.
Yes.
How does that work?
SMAS stacking is ideal for patients who need increased fullness in the midface. A strip of SMAS is created, and the SMAS on either side is brought together over this strip, creating a layered or stacked effect.
Let's move on to Skoog's facelift, one of the earlier SMAS techniques.
This technique, described in 1974, involves elevating the skin and SMAS together as a single unit, advancing them posteriorly onto the cheek and neck. It was a significant development in facelift surgery, recognizing the importance of the SMAS in facial rejuvenation.
Okay.
However, it doesn't effectively address nasolabial folds or anterior neck pull due to the tethering of the SMAS to lip elevators.
Let's discuss subcutaneous and sub-SMAS dissection techniques.
These involve lifting the SMAS along with the skin and subcutaneous tissues.
Okay.
The low SMAS technique focuses on the lower face and has a variable impact on the midface and periorbital regions.
Okay.
The high SMAS technique, popularized by Barton, addresses the midface and periorbital area in addition to the lower face.
In Hamra's composite facelift.
In this approach, the platysma muscle, subcutaneous fat, and the lower lid orbicularis oculi muscle are elevated as a single unit. This provides direct suspension of the malar and periorbital areas.
Interesting.
The skin and subcutaneous tissues are not elevated independently.
Then there's the lamellar SMAS facelift.
This technique involves dissecting the skin and SMAS as separate layers, allowing for independent advancement and tensioning of each layer.
Pittman's foundation facelift is another interesting variation.
In this technique, the SMAS platysma is separated from the underlying tissues while simultaneously raising a composite flap of SMAS platysma, subcutaneous fat, and skin.
Okay.
This allows for repositioning of the entire facial foundation.
Let's discuss the overall advantages and disadvantages of these subcutaneous and sub-SMAS techniques.
Compared to purely subcutaneous techniques, these offer more effective SMAS release, leading to better mobilization and a more noticeable impact on the anterior face. However, the dissection is deeper, potentially increasing the risk of facial nerve injury.
Okay.
Also, unless two planes of dissection are created above and below the SMAS, the skin, SMAS, and deep tissues will move together, which can compromise the SMAS layer's integrity.
Let's move on to the superiosteel facelift.
This technique, introduced by Tessier, elevates the midface periosteum as a single unit, avoiding dissection of the SMAS or skin as individual layers.
Okay.
This lifted unit is then redraped and fixed. It's important to note that this approach is not suitable for patients with significant skin redundancy in the nasolabial folds, jawline, or neck.
What are the advantages and disadvantages of this method?
The facial nerve is well protected because it lies deeper to the plane of dissection, and scarring is minimized with a temporal and intraoral approach.
Okay.
However, the superiosteel facelift, has a steep learning curve, and often requires endoscopic technology.
Right.
Also, it doesn't allow for independent reshaping of the skin or SMAS.
Finally, let's touch upon the temporal supraperiosteal dissection technique.
This endoscopic method, also known as the endoscopic brow mid-facelift, involves accessing the bony and soft tissues of the upper face through a temporal incision. The dissection occurs above the periosteum, extending around the lateral orbital rim and into the malar region. This technique utilizes the avascular plane between the SMAS and periosteum around the zygomatic arch.
Got it.
The malar fat pad is independently suspended from the temporal fascia using sutures.
Okay, we've covered a lot of ground regarding facelift techniques.
We have.
Let's take a moment to review the key points for each technique before moving on to ancillary considerations.
That sounds like a good plan. Let's quickly review the key points of each facelift technique to help you differentiate them for your exam.
Oh.
Subcutaneous facelifts are simple but may not last as long.
Right.
Deep subcutaneous facelifts use a thicker flap but have limitations in movement and fixation. SMAS application and imbrication are good options but carry a theoretical risk of nerve injury.
Okay.
The MACS lift is minimally invasive but might not be suitable for all patients.
Right.
Lateral sepiosectomy is good for those with full faces who need tissue reduction.
Okay.
SMAS stacking is ideal for adding fullness.
Makes sense.
Skoog's technique was groundbreaking, but has limitations in addressing certain areas. Subs SMAS dissections offer more effective SMAS release, but are more technically demanding.
All right.
The superiosteal facelift protects the facial nerve and minimizes scarring, but has a steep learning curve and limited ability to reshape individual layers.
Okay.
The temporal supraperiosteal dissection is a minimally invasive endoscopic technique, but requires specific expertise.
Those were excellent summaries.
Thanks.
Now let's discuss ancillary considerations that often accompany facelifts, beginning with malar enhancement.
Malar enhancement focuses on augmenting the cheekbones, which tend to flatten and descend with age.
Okay.
Restoring youthful contours in this area is crucial for achieving a natural-looking result.
What techniques are available for malar enhancement?
We can use implants fillers like fat or hydroxyapatite and autologous tissues, such as the SMAS.
Okay.
The goal is to either resuspend or reposition the descended malar fat pad.
Can you elaborate on specific techniques?
One approach is to fold and suture redundant SMAS onto the zygomatic body to enhance projection. Another is to anchor the cheek mass to the lateral orbital rim using permanent sutures, tendons, fascia, or Gore-Tex. Transblepharoplasty techniques can also be employed to suspend the cheek mass.
Okay.
Temporal supraperiosteal approaches, which we discussed earlier, can also elevate the cheek flap.
Right.
Some techniques specifically target the latotic orbicularis oculi muscle, which contributes to lower eyelid and cheek aging.
The source material mentions the malar septum.
Yes.
What is its relevance?
The malar septum is a structure composed of zygomatic cocutaneous ligaments.
Okay.
It contributes to the formation of malar mounds, which are those puffy areas that can develop in the cheeks, and also to postoperative edema. Adequately releasing the septum can help smooth the lower orbital and malar soft tissues.
Let's move on to nasolabial folds, another prominent sign of aging.
Facelift techniques are generally more effective in correcting the lower and middle thirds of the nasolabial fold, as these are addressed by repositioning the cheek tissues. The upper third can be more challenging to improve with a facelift alone.
What options do we have for treating deep nasolabial folds?
A sub-SMAS facelift, extending through the SMAS to the subcutaneous plane, can help stretch the nasolabial fold, releasing the dermal attachments of the fold and filling the space with fat or dermal fat grafts is another option.
Okay.
Soft tissue fillers can provide temporary smoothing, but results vary and they're not ideal for every patient.
Right.
Suction can be used cautiously for thick folds, but this technique can be unpredictable.
Next, let's discuss the aging lip.
Key signs of lip aging include an increased distance between the collimalar base and the upper vermilion border thinning of the lips, and volume loss in the vermilion resulting in a less pronounced pout.
What techniques can be used to rejuvenate the lips?
Lip lift procedures aim to shorten the distance between the nose and the upper lip.
Okay.
The vermilion advancement technique precisely repositions the Cupid's bow but leaves a scar on the lip margin. Another option is to remove skin along the alar and collimalar bases, which conceals the scar along the base of the nose.
How do we address volume loss?
We can restore volume using various methods like fat injections, fillers, alloderm dermal or fascial grafts, and tendon grafts.
Okay.
Using redundant SMAS for grafting is also a viable option.
Moving on to the jawline and chin, what techniques should we consider?
For a smoother jawline, slings and sutures can be placed along the mandibular border.
Okay.
However, caution is advised to avoid an overdone or unnatural appearance.
Got it.
Submandibular gland and digastric muscle excision, while advocated by some, is not widely accepted.
Oh,
Careful suction along the submandibular border can help contour the area but must be done judiciously to avoid irregularities.
what about chin ptosis, also known as witch's chin?
This condition presents as a drooping soft tissue mass below the lower mandibular border, often accompanied by a prominent submental crease.
Mm-hmm.
Resuspending the chin mass and placing a chin implant can effectively correct this.
Okay.
Releasing the mental crease and retaining ligaments through cutaneous dissection is essential during redraping.
Now let's discuss fat injections.
Fat injections or fat grafting are primarily used to restore volume loss and address tissue atrophy associated with aging.
What are the common recipient sites?
The lips, nasolabial folds, chin jawline pterotrophs, periorbital areas, zygomatic prominences, and labiomandibular folds are all common areas for fat grafting.
Are there any special considerations?
Slight overcorrection is necessary as some of the injected fat will be reabsorbed.
Right.
Repeat injections are often required for optimal results.
Mm-hmm.
The injected fat can be filtered or centrifuged before injection.
Okay.
Remember that the viability of fat injections can vary significantly.
Now let's shift our focus to perioperative management.
Okay.
What are the essential steps in preoperative assessment and management?
First and foremost, all NSAIDs and supplements like fish oils, garlic, ginkgo, and ginger must be discontinued for at least 2 weeks prior to surgery.
Right.
These can increase the risk of bleeding.
Okay.
Patients taking other anticoagulants like Plavix or Coumadin are generally not considered candidates for a facelift due to the high risk of bleeding complications.
Makes sense.
It is crucial to identify and address unrealistic expectations, as patient dissatisfaction is a significant concern in cosmetic surgery. Absolute contraindications for a facelift include active smoking, obesity, skin disorders like Ehlers-Danlos syndrome, uncontrolled systemic medical conditions like diabetes or hypertension, and a history of angina.
What about managing local anesthesia intraoperatively?
Allow at least 10 to 15 minutes for the local anesthetic with epinephrine to take effect before making the incision.
Okay.
This minimizes bleeding and provides a clear surgical field.
Blood pressure management is also crucial.
Yes, careful blood pressure management is essential to maintain a clean surgical field and minimize bleeding.
Right.
Clear guidelines for managing intraoperative hypertension should be established and communicated to the anesthesia team.
Okay.
Avoid placing the face in a dependent position to prevent venous pooling.
Got it.
Ensure the patient's body temperature is maintained and they are adequately covered.
What about hair preparation?
The patient's hair should be washed and braided or secured with rubber bands to keep it out of the surgical field.
What is the top priority in postoperative management?
Hematoma prevention is paramount.
Okay.
Keep the head of the bed elevated, ensure strict blood pressure control, and carefully evaluate all incisions, skin flap viability, and the presence of any hematomas on the first postoperative day.
What about drains?
Neck drains are typically used to collect serosanguinous drainage and prevent airway compromise.
Okay.
They are usually removed on the first or second postoperative day, depending on the amount of drainage.
How should dressings be managed?
Dressings should not be excessively tight, especially over the forehead, and undermine skin flaps. Avoid placing a dressing under the chin to allow easy monitoring for fluid collection in the neck.
How do we address small fluid collections?
Small fluid collections can be aspirated using an 18 or 20 gauge needle.
What if a hematoma develops?
Hematomas and continued bleeding require immediate surgical intervention to evacuate the blood. Smaller hematomas or fluid collections that appear after a few days can be treated with needle aspiration once they have liquefied.
What is the target blood pressure in the post-operative period?
The goal is to keep the systolic blood pressure below 139 mmHg to minimize the risk of hematoma formation.
What medications are commonly used for blood pressure control?
Chlorpromazine can be given postoperatively to manage rebound hypertension.
Okay.
A clonidine patch can be used for sustained intraoperative or postoperative hypertension.
Okay.
Clonidine can also be given preoperatively to patients prone to hypertension.
Uh-huh.
Labetalol can be administered intravenously to lower blood pressure rapidly.
Okay.
Hydralazine, a vasodilator, can be given intravenously when the heart rate is low.
Let's move on to potential complications, starting with the most common one, hematoma.
Hematoma occurs in about 2% to 3% of female patients. However, the incidence is significantly higher in males, around 8%, likely due to factors like simultaneous open neck surgery, use of platelet inhibitors, postoperative hypertension, and the rebound effect of epinephrine wearing off.
Makes sense.
Hematomas typically develop within the first 24 hours after surgery.
What about using tissue sealants to prevent hematomas?
Studies have shown that tissue sealants like fibrin glue do not significantly reduce the incidence of hematomas.
Do drains prevent hematomas?
Drains do not prevent hematomas, but can help reduce bruising.
Has tumescent infiltration been shown to be effective?
Tumescent infiltration using a large volume of fluid without epinephrine has been shown to reduce postoperative hematomas without significantly increasing wound bleeding or facial edema.
What types of nerve injuries can occur?
Both sensory and motor nerve injuries are possible.
Okay.
Sensory nerve damage to the skin flap is inevitable, but this disruption usually resolves within 12 months. The great auricular nerve is the most commonly injured sensory nerve with an incidence of up to 7%. If it is severed, immediate repair using microsurgical techniques is recommended.
Got it.
Unrecognized nerve injuries can occasionally lead to painful neuroma formation, although this is rare.
What about motor nerve injury?
Temporary motor nerve dysfunction in the first few hours after surgery is common due to the effects of local anesthesia.
Oh.
The buccal branch of the facial nerve is the most frequently injured motor nerve, but long-term consequences are rare due to the multiple interconnections between the buccal and zygomatic branches.
Okay.
The reported incidence of motor nerve injury is less than 1%.
What are the clinical manifestations of specific motor nerve injuries?
Paralysis of the marginal mandibular branch results in an inability to avert the lower lip, indicating mentalis muscle paralysis.
Got it.
Injury to the cervical branches innervating the platysma can cause platysma pseudoparalysis, characterized by lower lip asymmetry and a full denture smile. Patients typically recover fully from this injury within 6 months.
Are permanent facial nerve injuries common with sub-SMAS dissections?
No permanent facial nerve injuries are very rare with sub-SMAS dissections.
Let's move on to skin slough and necrosis.
Subcutaneous facelift techniques have a higher incidence of skin slough, around 4%, compared to sub-SMAS dissections, which have an incidence of about 1%.
Okay.
Common contributing factors include hematoma infection and smoking, which significantly increases the risk due to its negative impact on blood circulation.
How can we prevent skin slough?
Avoiding surgery on active smokers and minimizing tension on the skin flap are crucial.
Right.
If skin perfusion is compromised, postoperatively releasing skin sutures may be necessary to salvage the flap.
Okay.
Keep compromised areas moist with triple antibiotic ointment and impregnated gauze.
How common is infection after a facelift?
Infection is a rare complication occurring in less than 1% of cases.
Where do infections typically occur?
Most infections occur in the neck, likely due to its relatively less robust blood supply.
Okay.
Preauricular infections are often associated with Pseudomonas aeruginosa colonization of the ear canal. MRSA colonization of the nasal passages can also lead to infection.
What about methicillin-resistant Staphylococcus aureus, MRSA?
Preoperative screening and eradication of MRSA in nasal carriers is an important preventative measure.
How is MRSA eradicated?
Topical mupirocin ointment applied twice daily for 5 days, along with chlorhexidine soap body washes for 5 days, can effectively eradicate MRSA in nasal carriers.
How do we manage an established infection?
If infection is present, initiate empiric antibiotic therapy and obtain cultures.
Okay.
Incision and drainage may be necessary.
Yeah.
Once culture results are available, switch to targeted antibiotics and continue treatment for 1 to 2 weeks.
Let's discuss hypertrophic scars.
Hypertrophic scars are most common in the postauricular area where tension on the incision line is greatest.
How do we treat hypertrophic scars?
Intralesional steroid injections can help reduce redness, itching, and discomfort.
All right.
Scar revision surgery can be considered after at least 6 months to a year, allowing the scar to mature.
Are there any other complications?
Prolonged edema, ecchymosis, and contour irregularities are relatively common but difficult to quantify. Parotid fistulas are rare and usually respond to aspiration.
Okay.
Botulinum toxin injection into the parotid gland is another treatment option.
Okay.
Other rare complications include chronic pain salivary cysts, pigment changes, and postoperative thrombosis or pulmonary embolism.
Right.
The use of low molecular weight heparin for prophylaxis has been associated with a higher rate of postoperative bleeding compared to compression stockings and early mobilization.
The source material provides a list of the 10 most frequent complications.
Yes, let's go over them.
Okay.
Hematoma is the most common, accounting for about 70% of all complications.
Wow.
Then we have postoperative edema, ecchymosis, nerve injury, unacceptable scarring, hypertrophic, skin slew seromas, contour irregularities infection, and finally patient dissatisfaction.
Let's move on to the stigmata of facelifts, those telltale signs that can make a facelift look unnatural.
Those usually result from excessive tension on the skin layer or improper vectors of tension on the SMAS layer.
What are the specific stigmata we should be able to recognize?
Common stigmata include lateral sweep commissural distortion, Joker's lines, smile blocks, and flattening of facial contours.
What causes lateral sweep?
Lateral sweep occurs when there's strong lateral pull in the lower face without adequate treatment of the midface.
Okay.
This allows the naturally aging tissues to sag over the laterally pulled lower face, creating an unnatural appearance.
What about Joker's lines?
Joker's lines are accentuated nasolabial folds that result from sublunar hollowing caused by aggressive SMAS and skin release and excessive vertical pull.
How can we prevent Joker's lines?
A more conservative approach to SMAS and skin release combined with fat grafting to the submalar area can help prevent Joker's lines.
What are smile blocks?
Smile blocks are hypodynamic cheekbones that appear immobile during animation.
How can we correct smile blocks?
Soft tissue augmentation over the immobile area can improve the appearance of smile blocks by creating a smoother contour.
What's the key to avoiding that pulled appearance?
The key is to apply tension to the SMAS layer, not the skin.
Okay.
The skin should primarily serve as a covering, not a supporting structure.
Right.
Tension on the SMAS should be uniform to avoid distortions during facial expressions.
Are there any other stigmata we should be aware of?
Yes. Besides those, we've discussed other common stigmata include visible scars, hairline distortion, alopecia, tragal deformities, pixie ear deformity, and contour irregularities.
What causes visible scars?
Visible scars often result from improper incision placement, placing them too far anteriorly, or excessive tension on the skin flaps.
What's the best way to conceal scars?
Scars are best concealed when they follow natural anatomical contours and are free of tension.
How can we prevent hairline distortion?
Careful planning of incisions and avoiding aggressive excision can prevent distortion of the sideburn temporal hairline and occipital hairline.
Okay.
Ideally, the temporal hair should be no more than 4 to 5 centimeters from the lateral orbit.
Okay.
If significant superolateral movement of midfacial skin is anticipated, a sideburn incision should be incorporated into the plan.
Okay.
Avoid creating step-offs in the occipital hairline.
What about alopecia?
Alopecia can occur due to damage to hair follicles from cautery or excessive tension that compromises blood supply.
Right.
Focal hair transplantation can be performed to address persistent alopecia.
What are the characteristics of tragal deformities?
Tragal deformities can manifest as blunting of the pretragal depression, anterior displacement of the tragus, excessive fullness or hair growth on the tragus.
How can we prevent tragal deformities?
Avoid excessive tension on the skin closure, ensure precise placement of the incision at the tragal border, and consider defatting the thicker cheek skin and disrupting hair follicles before redraping to prevent excessive fullness and hair growth on the tragus.
What causes pixie ear deformity?
This deformity is characterized by inferior migration and axis distortion of the earlobe.
Okay.
It occurs when excessive tension is placed on the earlobe during closure.
How can we prevent pixie ear deformity?
Avoid putting tension on the earlobe during closure and transfer caudal forces to the postauricular fascia and skin. Leaving a 0.5 centimeter cuff of tissue around the earlobe during the initial incision can also help prevent this deformity. If a pixie ear deformity does occur, it can be corrected by transposing a portion of the SMAS flap posteriorly and attaching it to the mastoid fascia to provide support for the ear.
What are the common causes of contour irregularities?
Contour irregularities can be caused by variations in skin flap thickness, buccal fat pseudoherniation, submandibular gland ptosis, or digastric muscle hypertrophy.
Finally, let's touch on secondary facelifts.
Okay.
Why do patients seek secondary facelifts?
Patients may opt for secondary facelifts to address the natural progression of aging to correct an unsatisfactory outcome from a previous facelift or a combination of both.
What's the average time interval between primary and secondary facelifts?
Studies have shown that the average time between primary and secondary facelifts is about 9 years.
What are the essential considerations when performing a secondary facelift?
A thorough medical evaluation is crucial, as patients may have developed new medical conditions or started new medications since their previous surgery.
Right.
Carefully document any pre-existing deficits in sensation or facial animation.
Okay.
While obtaining the operative report from the previous facelift is helpful, it's not always available.
Are there any anatomical differences we should be aware of in secondary facelifts?
The SMAS layer tends to be thinner in secondary facelifts, and typically less skin can be excised.
Okay.
Scarring from the previous surgery increases the complexity of the procedure and raises concerns about potential facial nerve injury.
Right.
However, the skin flap may have a more robust blood supply due to the delay phenomenon.
What's the delay phenomenon?
The delay phenomenon refers to the improved blood flow to a tissue flap that has been previously elevated.
Okay.
This enhanced blood supply can make the skin flap more resilient during a secondary procedure.
What's particularly important to pay attention to during a secondary facelift?
Be mindful of the stigmata of facelifts we discussed earlier, as these can be addressed and prevented during the secondary procedure.
This has been a comprehensive overview of facelift consideration.
Yes, it has.
Let's test your knowledge with a case scenario.
Okay.
Imagine a patient with a history of smoking and hypertension who requests a facelift. What are your primary concerns?
Smoking and hypertension both present significant challenges in facelift surgery.
Right.
Smoking dramatically increases the risk of skin slough and necrosis due to compromised vascularity. Hypertension, if not meticulously controlled, can lead to hematoma formation, a serious complication.
How would you approach this patient?
The initial consultation is crucial.
Yeah.
Emphasize the importance of smoking cessation for at least several weeks prior to surgery.
Got it.
Explain the risks of continued smoking, particularly the potential for skin flap compromise.
Right.
For hypertension, obtain a detailed medical history and optimize blood pressure control in collaboration with their primary care physician or cardiologist. Ensure their blood pressure is well managed preoperatively and postoperatively.
Would you modify your surgical technique?
Given the increased risks, I'd choose a conservative approach.
Okay.
A sub-SMAS technique with meticulous handling of tissues and minimal undermining would be my preference. This reduces tension on the skin flaps and minimizes the risk of vascular compromise.
What about adjunctive measures like fibrin sealant or drains?
Fibrin sealant can be considered to aid in hemostasis, although evidence supporting its effectiveness is limited.
Okay.
Drains may help minimize fluid accumulation and reduce the risk of hematoma.
This case highlights the importance of thorough preoperative assessment and careful surgical planning.
Absolutely. These are essential for a successful facelift surgery and ensuring patient safety.
That concludes our deep dive into the world of facelifts, a high-yield topic for your board exams.
Right.
We've covered the science of facial aging surgical techniques, potential complications, and important considerations for managing complex patients. Remember, understanding the nuances of this procedure is key to becoming a competent and confident plastic surgeon.
Good luck with your studying.
Best of luck with your studies.